Hello, good afternoon from Madrid. I'm Alfonso Jurado, La Paz University Hospital. Here beside me is Ali, our scrubby nurse. Pilar is here, Santiago Jiménez Valero, Daniel Tebar, Carmen, a lot of people here helping us. And we are starting our second case of today. And Daniel Tebar is going to explain you the past history and everything.
So we are presenting a 73-year-old man with a medical history of hypertension and elevated LDL cholesterol. Was admitted to the hospital due to non-ST segment elevation, myocardial infarction with high troponin levels. An echo revealed a normal left ventricular ejection fraction but showed inferior akinesia. The patient's treatment plan included dual antiplatelet therapy, atorvastatin, ezetimibe, and bisoprolol. An urgent coronary angiography was performed, revealed occlusion of the right coronary artery as the culprit vessel. After thromboaspiration, the artery was successfully revascularized using a 3.5 by 36 millimeters DES. However, there was a persistent thrombus image at the proximal edge of the stent, so the decision was made not to post-dilate and check at a second procedure. Furthermore, two lesions were observed in the left anterior descending artery, one proximal and another in the distal mid-segment. We enrolled. This is the image of the right coronary artery.
Aquí la guía de presión, ¿vale?
And this is the LAD.
La de Abbott.
So we decide to enroll this patient in the combined intervention trial. The combined intervention trial will investigate whether a PCI revascularization strategy based on combined FFR and OCT assessment is superior to PCI revascularization strategy based on FFR on patients with multivessel coronary disease with any presentation. The combined intervention trial is the first in-line trial that will test focal percutaneous stenting for vulnerable plaque lesions independently from ischemia. Anterior descending artery lesions are planned to be evaluated with combined intervention criteria. The plan for today is to perform angioplastic guide by pressure wire and OCT in the anterior descending artery if necessary, and to conduct an intracoronary imaging examination of the stent in the right coronary artery. If required, post-dilatation of the stent will be also performed. So, Alfonso.
Thank you, Daniel. So I'm going to explain you the current setup. We are going through a 6 French sheath in the radial artery, in the right radial. We have reviewed the previous stent we implanted a few days ago, and I will show you the images. This is the first one, and angiographically the stent seems to be. Es verdad, perdón. Primero OCT, luego cambiamos. We have reviewed angiographically. It seems to be okay. As you see, the artery is quite static. And we perform an OCT, and if we can, we wanted to show, please, the OCT. If the screen can focus on the console. Just a second. No. We have moved to the other mode to perform the pressure wire, and we have to go back. So the plan is this: the stent. I am going to advance you some information. The stent with OCT was quite malapposed, especially in the proximal part. You can see in the angio that there is an erythematic zone in the mid part of the stent. And this one obviously is malapposed, and also the proximal part. So we decided not to post-dilate in the previous procedure because the thrombus burden was quite high, and in order to reduce the no reflow phenomena. So the patient was going to undergo Virginia. So as the patient was going to come back again to interrogate the lesion in the LAD, as Daniel explained to you, we have reviewed today with OCT the stent. I think Santiago can.
Yep.
Okay.
Yeah. You can see here it's a long stent. The distal border is okay. Will expand, and in some points there are remnants of thrombus attached to the struts, and in the proximal part there is an artery aneurysm with a diameter of more than 6 millimeters, and the proximal part of the stent seem to be okay, seem to be good opposed. So we have dilate with no compliant balloon. So Alfonso, if you want to continue.
Yeah, a 4.5 balloon just to oppose this proximal part, because this mid part of 6.5 millimeters in diameter it's impossible to oppose. So we have post dilated with a 4.5. We have a little bit of problems to enter with the 4.5, so we have used a conqueror balloon just to dilate a little bit the entrance of the stent that was. The strut was there was in a bad position. We're in a bad position, and after the conqueror, we post dilated with a 4.5. I think we have the image here. This is the stem boost, and this is the inflation. You can see there the proximal part of the balloon how expand the struts that were in a bad position there. So this is the result after the post-dilatation. This one is quite good. So we are moving to the left artery. You can see this diffusely this is LAD with severe angiographically severe lesion in the mid-distal part. So we are including the patient in the combined intervene trial, as Daniel said. That the PI is Selvin Getty, and we are doing now the pressure wide assessment with FFR. So we are moving in the Abbott software to the pressure wide mode. Okay. So we are following the steps. This is connected. Okay. Atmosfero. Estoy ahora con el 0, ¿vale? La vamos. We are flashing the wire. ¿Está hecho 0 ya? ¿Puedo abrir? María, ¿puedo abrir o no? No te oigo. We are restarting again because the 0 was not performed. I'm open to 0. You can do it. Okay, 0. We can flash again. Let's repeat all the steps. Abro aquí. Ok. Siguiente. Ok, entendemos. Sí, 2000 más. Ya está, estamos encendiendo. We're switching on the... Ok. Venga, vamos a darle aquí. We're going to advance the pressure wire distally to this lesion. There are some disease in the proximal part, so we have to interpret the results. Okay, let's go. I'm going to put the caudal view just to enter in the... Patient has sometimes does funny atrial arrhythmias without a wire there. Test, please. Okay, I'm selectively in the LAD, probably. Ok. No hace falta, no hace falta. Ok. Salino, por favor, la cosa Salino. Vale. Okay, we are flashing with Charline. Vale, ecualizamos cuando puedas, cuando se esté estable. We're going to equalize. Okay. Done. So in this study, you need to perform FFR. We are doing also RFR just for curiosity. Coge esta. RFR, ya. Dame un test, luego me da Salino. No sé, este no diagonal. Test, por favor. Test. Luego lo hagamos otra vez. Es que no sé si hace esto la arteria, que creo que sí, pero... Ok. Ahí se va a algún sitio extraño. Dame un test, por favor. No, un segundo. Ok, yo creo que estamos ahí. Voy a grabar esto. So we have advanced the wire distal to this lesion. Salino, por favor. Un poquito más. Okay. So we're going to wait a little bit to measure the RFR. You can bet, but probably it's going to be positive. And the study, the trial said if the pressure wire is positive, you under FFR under 0.75, you have to treat it, of course. And if not, we perform OCT to interrogate if the lesion has a vulnerable plaque there in the threshold. Okay, medimos ahí, María. So we're going to use intracoronary adenosine. Do another measurement, please, just to have two. Venga, ¿la adenosina la tienes? Sí. Tenemos atropina a mano, Pilar. Vale, medimos otra. So 0.87, 0.88 in the threshold under the threshold.
Tiene que pasar a FFR.
Sí. Pasamos a FFR, por favor. Is there any question of the audience, Tani, o no? Questions? No. Ok, estamos en FFR. A lo mejor notas una sensación un poco desagradable, es por una medicación, ¿vale? Si te pido que tosas, toses. Ya está. No, espera. Yo te aviso. So we are administering adenosine here, intracoronary adenosine. Let's see the ECG. Ok. 60, 120, 180. Ok. There is going to do. Ok. Salino, por favor. Dale con eso. Vale. Okay, I have administered almost 300 micrograms of adenosine. Medimos. Ok, yo creo que detenemos, ¿no? María.
Paramos.
Paramos. Ok, 0.72. We can review but I think it's quite stable, the pressure there. We can put again RFR just to see the pullback, but I think we have to treat this lesion, right? Okay. So RFR, I'm going to retrieve the wire here to check the pullback. 0.86 here, that was the initial RFR. And now here is a big jump proximal to the lesion that was angiography severe. And here the RFR is 0.94, 93. So I think it's obvious that the proximal part is not functionally severe. So I'm going to advance again the wire and probably treat the distal part. A ver. Ok. ¿Me das un test, por favor? Test. Ok, es difícil manejar la guía aquí. La voy a dejar ahí, que no quiero. Okay, so we are not doing more measurements. We're going to predilate this lesion through this wire. Let's check again the diameter in the angio. Ok. Me es un balón 2,5, semicomplete 2,5, 15 o así. 2.5 by 15. Es una casa mojada. So in this study, if we measure an FFR under 0.75, we have to treat the lesion and then optimize with OCT. So we are predilating the lesion, and then we will check switch again to the OCT mode to confirm the result of the stent.
So, Alfonso, we are asking us about the wire you are using now.
Yes, this is the pressure wire of Abbott. That is the conventional one. I don't know if Maria has a micro headphone. Probably can explain better than me that the characteristics of the wire. But this is a conventional wire, pressure wire from Abbott. ¿Tienes?
No tiene a mí.
Okay, let's go. Le pusimos más separina, ¿verdad? Hace un rato. Ok. A ver si navega bien. Test, por favor. All there, ¿no, Santi?
Yeah.
Venga, dale. 12, ¿vale? The vessel has been straightened with the wire. This is a bubble there, but the expansion of the balloon is okay. Down. I think it's enough. I'm going to retrieve the balloon. Test, please. Okay, I think it's enough. You can use this wire for the PCI. Probably conventional workhorse wire could work a little bit better through these curves of the distal vessel, but I think we have enough support to advance a stent. Okay. Nitro, por favor. Give me some nitro. Let's do another angio after nitroglycerin. 2 more. Okay, contrast. Okay, there. Okay, fine. Okay. So 2.5 something. Me das un stent give me a stent 2.5, 18 or 20. The balloon was 15, right? Me da igual, dime qué hay.
Había un 2,5 de 18.
Dame un science. Dámelo. So we're going to implant a Science 2.5 by 18. The balloon was 15 in length. So I think that we are going to cover the focal severe lesion that we have seen the jump in the FFR, in the RFR measurement. Any other question? No. Yes. Ok. Voy con la guía que se va de horas. Vale. So this trial and also the vulnerable trial that we are involved in, I'm going to explain some interesting points in these non-culprit vulnerable plaques or not vulnerable plaques. Yes, por favor. I think I'm almost there. Tess. Ok, ábrelo. Nominado, ¿eh? We are going up to nominal pressure as the vessel is quite diseased.
As there are no questions,
Juan tampoco.
as you have in place a pressure wire, would you be confident if the result of the pressure wire normalize after stent implantation, or do you prefer guiding with intracoronary imaging?
It's a very good question. There are some trials about the optimizing of the stents with pressure wire, but the results have not. When you do FFR or IFR or RFR after a stent, you always feel you have done something bad because the result is not one, never. And there are some trials explaining that if you optimize with post-dilatation and these things, probably you improve a little bit the measurement. But I feel more comfortable analyzing with imaging after the stent than with functional tests. Okay, Tess, por favor. And you?
No, I agree completely. I think there are different things. Functional assessment is preferable pre-intervention. After intervention, I think it's better to look what is interesting.
So let's do it. Let's do it, please. The question was prepared just to introduce the OCT analysis. It was quite reassuring that the measurement, the RFR, was negative just for the proximal part of the vessel that was a little bit diseased. We are using the same pressure wire to advance the OCT catheter. ¿Tienes guía? ¿Tienes Ali? Sí. Ok. No tengo mucha de distal para avanzar. I don't have a lot of distal vessel to advance the OCT catheter. Let's see if we can advance the lens distal to the stent. And no. Quite distal.
A little bit more.
A little bit more.
You are
probably there. Okay.
The distal border.
Okay. Let's continuar. Sí. Ok. Dame contraste, por favor. Vale, ok. Venga, ponemos eso. ¿Estamos preparados? Voy a comenzar. Inyectamos. Ok, sacamos. I was just in the distal edge of the stent, but we don't want to hurt anything with the wire distally. Let's see if the expansion is good. So Santiago is going to analyze with Maria the images. As you know, with this software, the distal and proximal parts are in the opposite way from the other software. This is the distal part.
There is a branch, side branch with a small amount of thrombus seems to be here. But probably it's a remnant of the predilatation of the lesion. There is some calcium outside of the stent, but the expansion is good. There's a mild malapposition in the proximal border, but it's very, very limited. I think it's not necessary to post-dilate. It's your decision.
There at the proximal part, what is the diameter? Is with 2.75 we achieve the probably a short one there.
¿Cuánto es esta medida? Que no me sale aquí. Que es que no lo veo.
2.95.
2.25.
95.
95. I don't see the number, sorry. Yeah, between 2.5, 2.9.
Maybe 2.75, a short one in the proximal part. Okay.
Yep.
Let's do this. Dame un NC 275.8 tenemos o algo así. ¿Me dejáis una Sion Blue, por favor? We're going to post-dilate the proximal part. I am going to try to advance another wire here because this wire is not doing these curves at the distal part, and I want to be safe there. Sí, primero la guía y luego el balón. ¿Es que, perdón? Sí.
Probably we could talk about the post-dilatation of these findings of stents. Minor malapposition is necessary to treat. In my opinion, in the majority of cases, there is not necessary. But when you look, this finding is difficult to resist to treat.
Yeah, especially in the proximal part, right?
But in the majority of cases, when there are few studies that have make a follow-up of these findings, but in the majority of cases, these findings resolve after a few months.
Vamos con el balón aquí. So as you have seen, I have advanced Sion Blue to the distal part of the vessel. In this area. It's quite safer now because I think we have to recheck with the OCT after the post-dilatation. To retrieve this one a little bit. And then I'm going to advance again this wire, just the proximal part of the stem. No?
The mid and proximal is
mid
not,
and proximal?
is not the proximal border is near the proximal border, but a few millimeters
Probably
inside
there.
the stem. Probably
okay.
there.
Okay. Arriba. A 12. Okay, down. Okay, dale. Okay, can we switch to the FFR mode just for curiosity to check the result after this optimization? Dame un test solo un poquito. Vale, everything seems to be okay. Si no se mueve el paciente, vale. Okay. Going to advance again the pressure wire. No. If I can. Okay, there. Perfect. Déjame el sensor este, ¿vale? I'm going to reconnect the wire. Okay. ¿Me das salino, por favor? Salino. ¿Venga un poquito más? Okay. So we are doing RFR. The initial measurement was 0.86, if I remember well. So this is the thing we were saying before. Dale, sí, instantánea. Directo, vamos a hacer otra. Let's do another one. ¿Te queda de nosina? Dale otra que he visto un 0,9 y me gusta más.
Estaba con salino y a lo mejor esperas un poco y sale más en reposo.
We are waiting a little bit more because we have flash with saline, but probably it's in the threshold. It's a little bit better than the initial measurement in the threshold or RFR. Dale, María, si quieres. It's 0.89. Dale, sí. We are doing FFR again with adenosine, just to show you the discussion we have had before, Santiago and me. And then we will do the OCT. ¿Atropina la tenéis a mano, Pilar? ¿Tienes? Sí. Okay, let's check the ECG.
And what do you think, Alfonso, about when you treat probably lipid-rich plaques, and after stent you induce some distal embolization? How can affect this the measurement of functional parameters?
Probably, dale, María, cuando quieras. Probably this is the reason of having these results after optimal stent implantation. Probably the distal embolization of the distal repercussion in the microcirculation is doing is responsible for this result. So here the FFR, okay, detener, is 0.2 0.79, 0.80. The initial one was 0.72. Is better, but the result is there. Probably there's something in the microcirculation in the distal vessel that is producing this. So we are retrieving this wire, the pressure wire, and performing the final OCT with the SIOM. Okay. Sacamos. Okay. Let's check. Déjame el rotor, por favor. Sí. Okay. Okay, I think it's not bad there. Let's go with the OCT catheter, please.
María, ponemos el pullback largo y así vemos también la parte más próxima.
Okay, Santiago is saying that we are doing the long pullback now, just to check not only the stent, but also the proximal part of the vessel that is diseased. Okay. And do this combine intervene, a really combine intervene, because the proximal part is functionally not significant, but we have the possibility to integrate as well with the OCT. I think I am now in the distal part. Okay.
It's enough.
Dame un test, por favor, que no sé el catéter está un poco... Test. Vale, es enough,
Okay.
¿no?
Yep.
Ok. Voy a lavar por dentro. Continuar. Ok, dale un poquito más de test. Ok. Preparados. Comenzar. ¿Tienen? Okay, I'm going to retrieve the OCT. ¿Vale? Está bien, vamos a parar.
Pero para saltar esto,
¿Me pones izquierda otra vez? Y dame un test, por favor. ¿Test?
you can see how the malposition has improved, has been corrected, but in the proximal part of the stent, there is some moderate fibrous-rich plaque and there's some lipid-rich tissue. Probably this zone is based on macrophages, as you can see here, and there is a plaque with a thick fibrous cap. This is not the objective of the combined intervention study. This is not a thin cut fibroateroma. It's a thick cap. You can see some cholesterol crystals inside the.
Estamos terminando, ¿vale? Va todo muy bien.
Inside the plaque.
Sí, va todo muy bien. Much better. There.
And as in many other cases, we have a proximal vessel that is not healthy, that's some amount of plaque, in this case lipid-rich plaques,
¿Vale?
some superficial calcium inside. You can see here another lipid-rich plaque. Again, there are macrophages inside with a dorsal shadowing.
The distal part of the stent is also okay,
Yeah,
Santi?
I show you. The distal part was we see previously, and we have not touched there, but you can see here there is no dissection.
Okay, because in the angio is a small plaque there, but I think
maybe that have some spasm. No, I think
okay.
there is no dissection in this point.
Okay.
And in the proximal part, you can see the malposition is practically corrected. And I was reviewing the mid and proximal vessel that is a diffuse disease vessel with a lot of pools of lipid plaque. And in the proximal part, there may be even a cap with a thinner fibrous cap. You can see here that the lipid content is very close to the vessel. Para medir ahora tengo que mantener el zoom y ahora measure. Maybe more than 100 microns. I think it's not really a thin fibrous cap.
Okay, so if you agree, Santi, yo creo que.
Yep.
So I think we have not to treat the proximal part. The distal part has been integrated with functional tests and also with OCT. The stent is okay, so we are finishing the case. I'm retrieving the wire. I have done also an angio after that. That is okay. So if there is no question, Danny, no question. So we are finishing the case and see you in future cases. Thank you.